Welcome to the 5-Second Rule podcast, where we drop it like it's hot on all epi and infection-related topics. I'm Jess Fargher, and my preferred pronouns are she and her.
And I'm Kelly Holmes, and my preferred pronouns are also she, her. So we have a new month and we have a new conversation. Today we're focusing on a critical and evolving area of infection prevention that I think you all will be interested in: high consequence infectious diseases, or HCIDs. I'm not sure which one is easier to say, and the role of emergency preparedness. From diseases like Ebola to COVID-19, HCIDs do require rapid response, specialized protocols, and strong coordination across our healthcare teams. Being prepared isn't just important, it's essential to protecting both patients and our healthcare personnel. So today we are joined by a very special guest, Carrie Billman, and she brings valuable experience in emergency preparedness and infection prevention. So Carrie's going to help us unpack what defines an HCID, how organizations can strengthen their readiness, and what you as the infection prevention professional should be thinking about right now. So before we dive in, I'm going to let Jess tell you a little bit about Carrie.
Hello, I have the great honor of introducing Carrie. Kelly kind of just did it, but I get to go over her wonderful bio and her credentials of MHPE, which we'll get to later, RN, and CIC. She is a senior infection preventionist who serves as the Director of Education and Training for the Biocontainment Unit, BCU for short, again, not sure which one's easier to say, at the Johns Hopkins Special Pathogen Center. She leads the design and implementation of training curriculum to prepare clinicians at Johns Hopkins and throughout the HHS Region 3 to safely care for patients requiring high-level isolation. Okay, so Carrie's super impressive, and she leads the BCU Infection Prevention team and the Trained Observer program, and she serves as an adjunct faculty for the Johns Hopkins School of Public Health. So listen up, because you are going to want to hear Carrie's insights and expertise on this hot and contagious topic of emergency preparedness.
Ba-bum-bum-bum. I love that.
I love that.
Yes. Welcome, Carrie. Just from your bio, you have so many interesting experiences that we could have an entire podcast about. But to start us off, you focused your work on emerging pathogens and high consequence infectious diseases. So how did you get into this space? And then what does your work look like on a day-to-day basis?
It's a great question. Like many in infection prevention, it's not a straight road. There are very few, I feel, direct paths to infection prevention just on the whole. So everybody kind of has a different way in. So I started at the bedside nurse, did that for about 12 years, and then was ready to do something a little different, but wanted to stay at the same facility that I was at. I'd been at Hopkins my entire career and really wanted to stay. So that's when I moved into infection prevention, and was doing, all the good work, boots on the ground, preventing infections and all of those things. And in right around this time that I transitioned into infection prevention, about a year prior, was the 2014 Ebola outbreak, which brought kind of the whole idea of these high consequence pathogens, the high consequence infectious diseases, whatever you want to call them. They're kind of used interchangeably, the HCID and the HCP. But that was really brought to the forefront. And that's when HHS decided to, add some additional federal funding to, at the time, have 10 regional treatment centers amongst all the HHS regions, to help train and really be able to keep staff safe in the instance of these types of pathogens. Johns Hopkins was one of the locations selected for, and that was the, at the time, only location within Region 3. They since have added an additional treatment center in Region 3. And so really, Hopkins took a really kind of novel approach compared to some of the other facilities. Everyone was kind of allowed to design how they wanted. And one of the things that they decided to do was embed infection prevention kind of all the way through our biocontainment unit from the get. So not only were the infection preventionists part of picking the PPE, choosing it, making sure we had processes for donning and doffing, but they were also embedded from a safety perspective, a risk perspective, in designing protocols and becoming what we considered trained observers at the time, and really developing that role. So once I got into infection prevention, I really took an interest in that and started helping to really push that role forward, develop it further, and really make sure that that program was able to be maintained. COVID hit. All of us infection preventionists became really popular. Really great time to be in infection control. As we all know, and those of us that came out on the other side and continued within public health and infection prevention. Then we had both re-emerging pathogens to deal with. And so from that point, I was actually pulled even further into the Biocontainment Unit, and now I am full-time with them, doing education, training, staff safety on a full-time basis.
Holy moly. I love that you said infection prevention was implemented or embedded from the beginning. And honestly, I wish that's how all other programs in healthcare worked. Like, just get us on the ground in the first place. I say us, IPs, because it makes a world of a difference. Did you notice that? Well, I guess since you were building the program, but world of a difference?
Yeah, I think so. Especially because I've encountered other programs, and infection prevention obviously has to be a part of high consequence pathogens at any level and any time they're being discussed. But there's a difference between just having them look at protocols and being actually a part of the patient care, being part of the activation and the care of those patients. Really, one of the things that I like to say when we are onboarding new infection preventionists and bringing them kind of onto the Biocontainment Unit, introducing them to that space, is when you go out on a regular unit, being an infection preventionist, you're honing that eye for risk. You're looking for what's wrong, for safety problems, and how you can fix them. How can you work within a workflow that's already established, but while still keeping patients safe? And that's something that is hard to teach just to someone else who may have another role. So while your RNs and your providers are also doing that on a daily basis, they're also thinking about their other job, which is the actual bedside care of that patient. So who better than the infection preventionist to be able to just focus on that one role and really be able to take it to the next level, because that is their only focus. They don't need to worry about what meds are due, turning a patient, IVs going off. That's not their problem. I need my nurses to be able to focus on that, be able to keep themselves safe. And it also gives our staff, when we are in a point of high level PPE and one of these activation processes, it just gives their minds the ability to not have to worry about being kept safe. They have someone whose job is specifically there to keep them safe. And it gives them a sense of kind of peace and safety, that they know that not only if they know the protocols and they're doing the right thing, they also have someone who's got their back at all times. Mm-hmm. Which is what we want everybody to think about IP all the time,
I know.
Right?
I was just thinking, like, we got your back. We don't just hold a clipboard.
Yes.
No. And it's
helping them feel safe.
The idea of embedding from the get, as opposed to the whole idea of asking for forgiveness instead of permission, which I feel like a lot of people do with IP. They just wait, and afterwards they're like, but it's fine the way we did it, right? Maybe not.
Never been guilty of anything like that in my entire life.
No, sure.
So with all of this, the preparedness reason, the Joint Commission, they're placing quite a bit of focus on that, as they should, but how are facilities supposed to prioritize which scenarios, which pathogens they should choose when building their preparedness program? And is there a right answer?
There is a right answer in that there isn't one pathogen they should be focusing on at any time. If they are doing the general kind of framework of identify, isolate, and inform, which is making sure they have the ability to cast that wide net to kind of get a patient and identify a patient that has travel history, usually, the right signs and symptoms, and the epi links those risks. If they can identify that patient, they know where to isolate them and how to isolate them, and then who to talk to get more answers and to figure out if this is really an area of concern. That's what everyone needs to be focusing on. They don't need to make it Ebola specific. It doesn't have to be Nipah virus specific. It doesn't have to be any of those things. Because if you do that framework, you will catch anything that's coming down the pike. And that's really the hard part. And also helping our staff who, there's so much screening, there's so many things they have to do on a daily basis with patients coming in, helping them understand that the purpose is to cast that wide net, and you will catch more people than actually are patients of concern, right? They're not all going to be PUIs, but hopefully we identify them first and then tease out the ones that we actually need to go and take those further steps with as far as public health measures and high level isolation. So there is no right answer, in that I don't want everybody to do the exact same thing. You need to have certain levels of PPE handy. You need to know where you're going to isolate your patient. You need to have the screening processes in place, but it's going to be a little different at every facility. Depends on your resources, depends on your space. Are you part of a system? Are you a standalone hospital? There are various things that are going to go into the decision making for the type of PPE you use and the type of isolation that you have available. And even down to the space where you would put the patient. Most of the time it's going to be a space in the ED for most facilities. Some identify a spot in the ICU. It really is going to be different depending on the level of care and the NSPS level that they're at.
Real quick, when you mentioned wide net, visually my brain was like, it's a fishing net just capturing all of the different bugs. Like that's what I'm visually picturing for all of these facilities. Just cast that wide net, collect them all, and then whatever's important, like put that focus on that today. Anyways, for those visual people out there.
That's exactly what we want. We want to capture all the people and then tease out the ones that are actually ones we need to worry about, because most of them are not going to be. And they're the symptoms alone are enough to cast that wide net. Like, oh, you have fever, you have a cough, you have nausea, vomiting. That's 99.9% of the ED. So it's going to be a wide net, but they're not all going to have travel to significant areas. And really identifying those significant areas are important too. Not every area is created equal, as far as what they have going on from a pathogen perspective.
Yeah, that was what I was thinking when you were talking, that identify step is the, really critical piece, because I know we've probably all seen a measles case or a tuberculosis case. Like they don't answer the questions, perhaps clearly upon that initial screen. And so then we wind up missing them for a few hours or maybe longer in the ED. So what do you think works the best as far as like staying in touch with that identify piece? Like where do IPs or the facility in general, like go to check to be like, okay, here's what we need to be careful of. We have a major airport in our city. Like here's what's at risk. Like how do we keep up to date with that?
There's a lot of ways to do it. I do recommend staying on top of any of the electronic ways that you're using for screening. Use those tools. Those tools are there for a reason. If you're, just for an example, if you use the Epic platform, some facilities use Epic. Epic has built-in screening, and they have a travel advisory board that they help to update that screening. So I think that's important to utilize any electronic tools that you have at your disposal. I think really doing the research and trying to keep up to date and updating when there are major outbreaks in the world, especially if they're in areas that we are not used to, and then really clarifying with your intake areas where they're doing the screening exactly what they're looking for. So I think that kind of closed loop communication is important. So the patient tells you, oh, I traveled last week to Africa. Okay, great. Africa is a very large place with a ton of different countries, all with their own, different different organisms that might be of concern, different things that you may be doing while you're traveling there. There's so many things. So just a blanket statement of Africa is not enough. We need more information. And we need to clarify that information. There are a lot of countries that sound very similar. If your patient or your family members don't speak English primarily, they have strong accents. We want to just make sure we've clarified to the absolute best of your ability. Use translation services when necessary. because there's a difference between the Democratic Republic of Congo and the Congo. They're two totally different places, but they do sound very alike, and not everybody knows that those are two different places. So I really think when you talk to your screening staff, having that that conversation about closed loop, just verifying all that information. Yes, the patients get a little testy when you ask the same questions over and over, but there's a reason it needs to be done that way, to really make sure that we aren't missing anything, and that we're capturing it correctly. And the time frame makes a difference too, because they're like, oh, it's just there, and it was 6 months ago. But I'd rather capture that person, early, and then figure out, oh, it was 6 months ago. I'm not worried about 6 months ago. You go, glad you enjoyed your trip. Tell me more about it later. Let's move on and figure out why you don't feel well. But
back to that wide net idea. Yeah, just ask the big question, drill down. And okay, so that was really helpful. And then to kind of, build off of that. So we know that the identify step is critically important, and there's multiple ways people can come in to the facility. It's not just the ED. So making sure we're aware of all those like entry points. But what other big gaps are you seeing right now, like across healthcare systems, that IPs need to be aware of, or something we could focus on?
I think the idea of standard precautions has been lost along the way.
Oh, yes.
Universal and standard precautions in healthcare in general has just been lost. So really encouraging the concepts of that, the use of, the person in front of you is coughing. Put a mask on them, put a mask on you. It's, those types of things are a little bit of a lost art. So I think that is a gap for sure. I think making sure that you have updated all of your points of entry. So to your point, it's not always just the ED. The ED is obviously a large risk area, but if you have urgent cares, if you have clinics, if you have direct admissions, anything like that, any area where you may have to use your screening tool, we want you to be able to keep that as updated as possible. And that's a little extra legwork, to make sure that you've checked all those boxes, but it really will be helpful in the long run. So I think that is a big gap. And then just kind of waiting around to either isolate or inform those extra pieces. Once you've kind of figured out there's something that's, I'm getting a flag in my electronic record, it's saying that I should be worried. Like, what do you do right then? Do you immediately isolate them? Do you immediately call someone? There's a lot of kind of lag where people just don't want to deal with that extra added burden, so it doesn't happen. So really kind of helping explain to your staff that you're doing this for their safety. This is the, why we're doing this. Not only do we want to help the patient, but we'd like to keep our staff safe and not exposed as well.
So the common denominator from what you're saying is communication. Even when it comes to isolation, identifying, it's communication.
Absolutely.
Okay. I can get on board with that.
Yeah.
Super, super critical. So how does your position allow you to communicate effectively during those super stressful, high impact situations? You are in a very specific role, so I am curious to know how that works.
Well, I think it helps when you're at a facility or you're known even in your region, in your area, as being a subject matter expert. It gives people okay, well, we don't know what to do. We know who to call. And that's kind of one of the, yeah, that's me, right? I'm Ebola buster. I don't know, and something like that. It's just one of those things where you want to make sure that people, they feel safer when they know who to call. And that comes back to, once again, that 3I framework, it really shapes everything. So that's your inform. I don't know what to do about this. I don't even know why I'm getting a flag on my chart. I don't understand, what this person could have because I don't know anything about this area that they travel to. But I know I can call my infection prevention team and they're going to be able to help me figure out how to keep myself safe, what PPE I need to wear. And then, within my hospital, they know they can call us at any time. Our biocontainment unit is always able to answer those questions and help and figure out exactly why this patient flagged and what kind of concern we have to have. I do always recommend, if it's possible, to have as strong of a relationship with your public health professionals as possible, your state and local health departments. If you can be besties to the best of your abilities. It's a good thing, so that when you need to call, so if you don't have a biocontainment unit at your hospital, and there's only 13 of them in the country, so most places don't, you need someone who's an expert. Not every facility has infectious disease staff on. There's some that just have ID staff that cover multiple hospitals. They cover a system. They may not be physically present. So knowing who to call to get those answers and not just trying to muddle through Google and figure it out on your own is super important.
Yes. So partnering with our public health partners, the IP being able to call their public health helpers in times like these. Yeah.
Yes. And we know they're not all created equal, right? It's everybody not going to have the gold standard of a perfect relationship there. But if you can find that one I highly recommend it.
I highly recommend cookies. Cookies bring everyone together, or apple pie. But stay away from Google. Communicate with health department. Bring food. Got it.
Bring snacks. Yes.
Build those relationships. Yes.
That's universal for all things. Feed them and they will come.
Yes. Oh, that should be on a mug.
How I live my life as an educator. Feed them. They will come.
Yes.
Oh, well, that's a great segue. Yeah, to the next question, because, part of that Joint Commission standard is competencies. And I think, just personally, I've heard lots of conversations about how to operationalize these competencies. What does that mean? What does that look like? So, have you found an effective way to help train and then confirm competencies, or what do you feel like would be a good way to confirm competencies so that we know that this frontline worker is confident in what they're supposed to do and that they feel comfortable caring for the patient in high stress situations?
So I think the idea of using the word competency is always hard. It is very specific what the definition is to truly say that someone is competent with a skill, task, or a concept. But I think really what I have found is making sure that the right people who need to receive that education are frontline leaders. There's two parts to it. One is helping them understand why it's so necessary, how this is actually going to keep them safe, why we are pushing it. It's not just because we're trying to meet a regulatory guideline. There are safety reasons for why we are doing this. So I think that's really important. And then working to find a way to embed it into already established education. As we know, there's so many things that already require educational days, webinars, modules, whatever, that it's hard to find time. People, time, money, it's hard to find. So if you already have established education, skills days, competency days, what have you, trying to embed the concepts of what you're looking for here into those educational days can actually help it get done, because really finding the time to do it is half the battle. I would recommend kind of a background information on what high consequence pathogens are. They are not what everybody thinks necessarily off the top of their head. It's not COVID. It's not measles. It's not mumps. It's, the types of organisms that are low incidence, high mortality, and have little to no medical countermeasures. So that's the Ebolas of the world. That's Nipah virus. That's Lassa. There are things like that are completely different. So we just want them to understand the different concepts of that, and then really as much hands-on PPE that you can do to introduce the types of PPE ensembles that you will be using at your institution. And if you can do multiple iterations of that, even like one or two back to back, getting muscle memory so that it seems familiar is going to help in those high stress situations. Okay, I can look at this. I have a just-in-time training plan available to me, which could be videos of what it looks like to don and doff that PPE. It could be pictures that show exactly the steps that need to happen, so that it's not the first time they're seeing it when they actually have to use it. They may not have it off the top of their head. It might not be perfectly memorized 100%, but really what we found most effective at making our staff feel that they are able to be safe in those situations is the ability to have seen it before and make it as familiar as possible. So I think that is important. There are definitely things you can do to check a box, which is, online modules. But we know online modules only get you so far. Mm-hmm. That's a whole lot of clicking for no reason, right? We all know. Everybody knows. And will that meet a requirement? So you can say, yes, my staff all watched this video and took a 4-question quiz afterwards. Okay. And that may meet your competency and that may meet your actual qualification, but is it actually going to help your staff? So I encourage people to think beyond that. It's fine to do that because there is some merit in it. It's at least there. It's available to pull. You can see who's done it and who hasn't very easily. But I think adding that hands-on component is absolutely essential.
How often do you do that, Carrie, with your team? Like, how often do you do it so that they stay like, oh, yes, this is the first thing I put on, the second thing, the third thing?
So we are special because we do, this is like
I
our
know.
level. So from the biocontainment standpoint, we train quarterly. So all of our staff quarterly will do a full round of multiple rounds of PPE. We have 2 ensembles that we use, one for a doffing assistant and one for our healthcare providers. They will do both of those ensembles. They will don, they will doff. They will often do skills or certain kind of scenarios while in the PPE and go through at least one protocol quarterly. To make sure that they're up to date. We also have several exercises and things that run throughout the year, hands-on full-scale exercises as well. So that's what we do. Now, what every other facility needs to do, you're not going to get quarterly training. It's really identifying, I think, those that are able to help you deliver that training. So is it all on the shoulders of our IPs? Can our nurse educators and nurse education offices help us? Can your LCNs and your charge nurses and kind of those staff that are established, not brand new and not necessarily one foot out the door? Those are the people I'm looking for to help me deliver training to facilities that don't have a biocontainment team to provide that type of education. So if you can get annually, that's, I think, great at most facilities. If you have the ability to do more than that, then absolute kudos, snaps to you. But I'm thinking if you can do annually, that is definitely I think would be wonderful if you can get everybody that you think is truly at risk, right? So these are going to be your ED folks, your intake folks. That would be amazing.
I think quarterly PPE is a good fit for most facilities just because you do need to keep retraining, and I don't believe in the word perfect, so practice makes it really good. And even as an IP who was doing the education, I always thought by giving that education, I was re-educating myself because you do lose those little things. There's only so many penguins on your mental iceberg that you can hold, and sometimes they fall off. I'm so sorry, penguin, but anyways. I think getting back to it, quarterly is a really good idea for most places, and if you can make it, do it.
Well, and here's an added benefit of increased practicing doing your high level PPE. So the PPE that you would use for one of these high consequence pathogens, that shows you the right way to put on and take PPE, right? Which we know not everybody does. They may learn the right way when they first learn it, but we know they're not doing that in everyday practice. So one of the benefits that we have seen amongst our staff that work on the biocontainment unit is when they go back to their home units, they have better glove removal, hand hygiene. They take their gowns off the correct way because it's that muscle memory they're using on the BCU. So it's an added benefit just for your entire infection prevention program to do training for high consequence pathogens. It only benefits kind of that downhill kind of trickle there.
I like it. You've kind of already answered my next question, but I'm going to ask it anyways, because your background is very interesting. And I said I was going to get back to this. You have a master's in health professions education, and most people in the public health field or infection prevention, they have to educate, they have to communicate, and they don't have that formal education experience. So on the fly, they have to become teachers overnight. Well, at least that's how it felt for me. And I fully believe that education can make a huge difference. You've already said that those competencies, yes, checkbox, but it's learning the why behind it that really makes the difference. So, how has your higher education helped you create those training programs and the training preparedness?
I think it really has assisted in helping figure out how to train every level of person I need to talk to about this, because I don't, every facility has multiple different levels of staff that need to understand these concepts. So your providers, your infectious disease physicians, they need to understand. Your C-suite, your leadership, they need to understand. I need to be able to, I need to be able to eloquently explain why I need money to pay nurses to come for an entire day to learn these concepts. Like, where's that money coming from? Not coming from me. It's coming from way up there. So how do I make my case to those folks? But at the same time, I need to explain to clin-techs in the ED about exactly why this is important and how they can safely do A, B, and C. So I think the degree was most helpful there. When looking to go back and get my master's, I originally looked as a nurse at a master's in nursing or nursing education, and really found that those programs were designed to teach new nurses how to become nurses. And I'm like, that's not really what is beneficial in my role. I need to figure out how to train adults, how to educate adults, and I need to be able to speak to everyone within a healthcare kind of level. So I'm doing, and that really benefits all of infection prevention. We do education with our environmental services staff, our nutrition staff, the kitchens. There are so many different levels of understanding and different levels of kind of education that you're going to come in contact with, but the same concepts need to be taught. So I think that's been the most helpful, is feeling like I can teach the same concepts to no matter whomever I'm speaking to. And I think that's been really helpful, because especially in IP, you got get nurses, you got some MPHs, you have all of that. But I feel like the more education backgrounds and masters in education we can have, because you're right, we get thrown in, you're like, oh, well, you already know how to do that. Teach these people how to do that. And you're like, okay. And not everybody's great at that. Not everybody's good at one-to-one education. Not everybody wants to talk to a big room full of people, especially if they feel, if your facility has more of that hierarchical feeling, right? Some places do. They feel like, oh, well, these are the people who really know, and then the rest of us are just down here. There's different cultures in different places. So, to be able to speak clearly and eloquently and get your point across is super helpful. So that's been the most beneficial, I think, for me. And finding out what works for everybody.
Now I think I have to change my master's degree. Gosh dang it.
I think it's just so fascinating. Infection preventionists are such smart people, and they bring in so many different expertise, in education, in nursing, in public health, in epidemiology, even construction or water management. So it is just all encompassing and, forever impressive to me. So for infection prevention professionals who are listening today, what are some practical things that they could do to strengthen their preparedness? You've really hit on a lot of really helpful things already. But, say it's an IP outside of a large academic medical center, they're maybe even doing two roles. Maybe they're the wound care nurse and the IP, or, multiple hats that they're wearing. Do you have any advice for that?
Yeah, start small. Figure out your PPE. If you can start there, figure out what does your PPE ensemble look like, because the guidance given to us by the CDC is pretty basic. It says you have to have at least this, but it doesn't say use this exact type of boot, glove, gown, overall, whatever the case may be. And even amongst the 13 treatment centers in the country, we all use different PPE. It all meets the same standards, but it is different. So if you're at a facility, and I would say identify what your PPE ensemble looks like and make sure you have protocols to both don it and doff it. If you go to your protocol and somebody says, oh yeah, we've got protocols, and it says Ebola 2014 at the top, it's time to relook. It's time to redo. We've learned a lot of things since 2014, as we have almost everything else in infection prevention. So it's time to dust it off, go back through it. Also check the PPE, because if you haven't used it, it's probably still from 2014 and likely expired. So I would say that's the easiest place to start, is making sure you have that ensemble and you have a protocol, because you can't teach anybody if you don't know, what you're really working with. And then the second step to that is identifying that isolation space. Do I have an AIIR that I can put them in? Is it, the most out of the way? Is it have the best possible working room for my staff? Those little things that you can do. And then use your resources. Every hospital in this country has a regional treatment center in their region. So reach out to the organizations that can help link you up with that. Yes, Google can do it too, but you can reach out to, you might get there eventually. If you Google around far enough. But, the NETEC organization does link us all together, and they will make sure they get you to the right people who can help answer those questions, pretty easily for you. So that would be my recommendation for those folks who are just like, okay, I need to at least get something started, something done. Start small.
Oh, that's so helpful, especially like the resources of, okay, I'm sitting at my computer, I'm trying to update this policy, figure out the PPE, where do I go? So that is really helpful, I think. And I'm hearing you say there's more than one way to do things correctly. So it doesn't have to be identical everywhere you go. There's, more than one way to do it right.
And if you are part of a system, even if you're a small hospital, try to get your whole system on board. So you're all sharing the same things. Don't do extra work. Maybe one of your sister hospitals has already figured it out. Do what they do.
Don't reinvent.
Yeah.
Lesson of today regarding preparedness: identify, isolate, communicate, bring cookies. Got it.
Yes. Yeah.
And explain the why.
Yes. The why is very important.
Kelly and I, even though, so she was right, by the way, Kelly, we could do a whole, maybe 3 more episodes with Carrie.
Right.
Fully believe it.
I don't want to let her go. I know.
I know. We are going to do something even more fun, because obviously talking to you has been a hoot and a holler. And it is a little lightning round. And I'm going to ask the first question, and I'm super excited about it, because the nerd's coming out of me, and I need to know, what is your favorite infectious disease or / pathogen?
I wish I could tell you that it was one of the high consequence ones, but it's actually not. This is a question that my department, my infection prevention department, uses during interviews. And it has helped us sniff out some folks that were not designed for infection prevention. When we asked, what's your favorite infectious disease? They said germs. And you're like, okay, this might not be for you. Germs.
That's an umbrella answer.
So, you can use this question for many things. So from my perspective, my favorite infectious disease is Burkholderia cepacia. I do find it fascinating that it can wreak havoc in certain populations and, barely make a dent in others. Our cystic fibrosis population can absolutely be ravaged when they encounter that organism. But others have probably never heard of it. It's never something that really factors into their life or their lifestyle. So I think that's a really interesting organism to know more about. My background bedside is in pediatrics, and so took care of a lot of cystic fibrosis patients, and it was always one that I needed to know more about.
I feel like you'd be a ringer. Go ahead, Jess.
I was going to say it real quick. Well, not real quick. Say it one more time slowly for the people who want to know more about what you just talked about.
Burkholderia cepacia.
I'm so impressed by people who can say those type of words.
I didn't say it right for a while, and I might not even be saying it right now. That's how I say it in my head. So, come at me, people, if I'm saying it wrong or you say it differently, but that's how it says in my brain. And
I love it.
Yes, you'd be a ringer at IP trivia for sure, if that ever came up.
That's something we should do. Bring on other people, make teams. Oh, Kelly, what a great idea.
I do love a good Kahoot. If you have one of those available, those are fun.
Awesome.
So what's your favorite show or podcast right now? Do you have a recommendation for us?
Sure.
Oh, that's a great question. This is terrible.
No, do it.
Show wise, we don't watch a ton of TV because we don't have time in our house, but I like things that I can watch with my 2 teenage boys and my husband. And we watched Fear Factor, Fear House, and all of the gross things that they did together. And of course, I'm looking at them from like a germ perspective. I'm like, okay, so you just ate a raw cow's tongue. What could you possibly have contracted from that? So it's probably not how it's intended to be scary, gross, or having fear of. But for me, I was fascinated by it. So yeah, that's what we've been watching, and that's a weird answer, but here you are.
I love that answer because I think with anyone in healthcare who's watching those healthcare shows or, in the ED, but you're like, how can I find infection prevention and Fear Factor? Go.
Right. Because, I mean, that's the thing. People are all dissecting the Pit and Grey's Anatomy and all of those things, which are great shows. I like them as well. But really finding the weird infection prevention questions is kind of my thing, I guess.
Okay.
I wonder if they have an IP on their production team. I know, right? Future job role.
That's a great idea. Oh my gosh. Talk about Googling. I'm going to ask me like, so how many of your contestants got sick? Would you like to prevent that from happening again? Contact me.
Dang it.
This one's a fun one. Okay, what's one piece of advice that you would give to your younger self, or maybe that you give to your teenage boys?
Teenage boys, take more showers. That one's an easy one. To my younger self, I would say trust the process. The opportunities that you thought you missed out on, the failures, were obviously not meant to be. They weren't the right moment to move into different places, different areas. And so it is, like I said, a very winding road to get me to my position and where I am right now. I wouldn't be doing anything else. I love my job. I love my coworkers. I love the place that I work. And so not everybody gets to say that, and not everybody can say that. So, and if I had taken any of those opportunities or gotten positions or promotions when I so very much thought I deserved them, then I probably wouldn't be here. So I'm pretty grateful that I trusted the process.
That gives me goosebumps. That's really good advice.
Okay, one last question.
Yes.
Do you or do you not believe in the 5-second rule?
When it's convenient for me, sometimes I do believe in it. But from a professional
it's a risk assessment. It's all about a risk assessment.
Always a risk assessment done. I will say, on that plane I was just on, I watched a man's toddler drop his binky, and the man picked it up and put it back in the child's mouth. And I was like, and we're dead. We're all dead. I don't know. This is terrible. So yes, most of the time, I say no 5-second rule. It does not exist, but especially in the case of a binky on an airplane floor. But occasionally I have been known
yeah.
By the time I had my third kid, it was definitely up off the floor and into their mouth. And they all are fine. They have strong immune systems.
Strong, good titers to all the things. And, when you're on a plane, so you can't make a scene. And my coworker's sitting next to me, and I'm like grabbing his arm. Like, did you see that? Did you see it? Oh, God. Yeah.
Oh, my gosh. That's amazing. Well, Carrie, thank you so much. That's it for today's episode. Jess and I probably both wish that we could keep you on forever. But a big thank you for taking time out of your travel schedule. I know you just got back from Germany. So your insights on the high consequence infectious diseases and how we can better prepare for that as a nation and as a profession have been very valuable. So thank you for your time.
Absolutely. So happy to do it.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.